It's just a great pleasure to be here. I just want to thank the Madurai team for giving me the opportunity. I was and is a Madurai guy at heart, and it's great to see a lot of people from Madurai. And I want to thank all of you for being here, and special thanks to a couple of people from Madurai Kamaraj University, Dr. Ramasamy and Vel Murugan, who have come all the way. Because there are so many controversies here, no one knows who is right and who is wrong, so I'm going to stimulate more controversies. So I've got no conflict of interest. This is a slide. All speakers podnum sollite irpen. In the pakkam ambulance and the pakkam the funeral service or advertisement. So I've not gotten any money for this talk in terms of presentation. Ellarum onnuthula agree pandrom. Definition of gestational diabetes. This is controversial kediyadhu. Adhe doubtful irukku enakku. Carbohydrate intolerance resulting in hypoglycemia of variable severity with onset of first recognition during pregnancy and adoda consensus mudinjadhu adukku mele ellame prachanai da. So why are we here? The only non-controversial area in GDM is the fact that there are many controversies in screening, diagnosis and management. Enga poringa nu portharukku endocrinologist, diabetologist, obstetrician, everyone does their own thing and strongly feels that they're absolutely right and the other guy is rubbish. Okay, so let us see what evidence we've got here. What are the areas? How and when to diagnose? Yarku test panna porom? Should we really treat it? What are the optimal glucose targets? சில பேர் 1.5 மணி நேரத்துல பண்றாங்க, சில பேர் 2 மணி நேரத்துல பண்றாங்க, சில பேர் 4 இட்லி சாப்பிட்டு 1.5 மணி நேரம் கழிச்சு பண்றாங்க. So we don't know what is right. 1 hour or 2 hour, what is the optimal treatment? Metformin use பண்ணலாமா? Insulin போடணுமா? Insulinல எந்த type of insulin போடுறது? And what time do you want to deliver? And இப்போ என்ன ஆயிட்டு இருக்கு, நான் வந்து ஒரு ரெண்டு ஏரியா மட்டும் தான் ஃபோக்கஸ் பண்ண போறேன் for want of time. I'm just going to mainly focus on screening and diagnosis and use of oral agents in pregnancy. I think என்னங்க ஏதா கான்ட்ரோவர்ஷியா? So இப்போ என்ன ஆயிட்டு இருக்குன்னா, even within our own institution, you name any even corporate hospitals, someone does random glucose, someone does 1.5 pp glucose, someone does 100 gram OGT based on ACOG criteria, someone asks for a 75 gram OGT based on DIPSI guidelines or the International Association guidelines, and someone just does 50 gram screening test. I hope at least we can agree on certain things at the end of the talk today. There is definite risks of diabetes in pregnancy and gestational diabetes in pregnancy. A lot of studies have shown this. In gestational diabetes, you do have an increased risk of neonatal hypoglycemia, perinatal death, and commonly to both pre-existing diabetes and gestational, fetal macrosomia, birth trauma, induction of labor, neonatal morbidity, and later development of obesity and diabetes. This was the 2010 article, again saying that treating gestational diabetes is worth it. This is a meta-analysis of quite a lot of trials looking at perinatal mortality, large for gestational age, macrosomia, birth trauma, neonatal intensive care unit. It looks as though if you intervene and treat it, the outcomes are much better than not treating it. So let us not have any controversies over there. And now, persona many screening and diagnosis and use of oral agents in pregnancy. I think for all practical purposes, we have to decide on one of the three. So sauriyathu pannittu irukka koodadhu. Indha moonu kullare edha pannalam based on current evidence. If you are a patriotic Indian, you can do DIPSI guidelines. This is the Indian specific guidelines. Dr. Seshia Group has come up with this protocol, apparently accepted by the World Health Organization as well. Or otherwise, you can use a two-step process. Again, gynecologists tend to prefer the 50 gram screening test followed by a 100 gram OGTT. That's what the American College of Obstetrics and Gynecology and the National Institute of Health suggests. Or the third one is this International Association of Diabetes Pregnancy Study Group criteria, which is a one-step process based on a 75 gram oral glucose tolerance test. So, in the moonuthukulla dhaan edavadhu irundhanum DIPSI patti pesren. The concept is very simple. The lady walks into your clinic anytime, irrespective of fasting or having a food. You give her 75 grams of glucose, and 2 hours later you do a glucose. If it's more than or equal to 140, you diagnose gestational diabetes. And if it's more than or equal to 200, it's over diabetes. And this is what it is. What they say is that it's very easy to do. You don't need to be fasting. People coming from faraway areas, they don't need to come back. So on the face of it, looks very easy. They've got another thing which is slightly confusing to me. 2 hour more than or equal to 120 now, they've branded this as something called as decreasing gestational glucose tolerance. And inga dhaan konja confusion vara aarambikudhu. So appo 121 irundha what are we going to do la? Are we going to brand them as kutha aarambinga neenga monitor panna aarambinga nu solla poruma illaya theriyala, we don't know. And I just wonder, 75 gram oral glucose kuduthitana, it's very unusual to see a glucose less than 120. So you're going to detect a large number of patients based on this, and I think this area is a bit confusing to me. Again, I would be happy if one of the obstetricians or some of the diabetes endocrine team would tell their views. So, ellathukkum pros and cons irukku. What are the good things about DIPSI guideline? It's an Indian specific guideline, so we need to be very proud about it. And no fasting, it can be done any time of the day, and it serves both as a screening and diagnostic test. What is the evidence? To me, I think the evidence is pretty weak. There is one study done by Balaji and Dr. Seshia group looking at around 1,500 patients applying this protocol, but they didn't have a control group comparing either IAD-PSG or ACOG criteria. So it was just done based on this, and they said that the prevalence of GDM is around 13%. And this decreasing glucose gestational tolerance, I just believe it's scope for more confusion and more unnecessary testing. What does the American College of Gynecologists do? I forgot to include the first slide. It's a 50 gram screening test. So the patient comes in any time of the day to you, you give 50 grams of oral glucose, and you do a 1 hour glucose value. And they say that if it's more than 130, again they're not very clear, they say between 130 to 140, you need to go to the next step, the next day. It's a 100 gram, 3 hour GTT, and these are the numbers that you need to remember. If the fasting is more than or equal to 95, 1 hour 180, 2 hour 155, and 3 hour 140. Bit of confusing numbers to remember, but 95, 180, 155, 140. If any two of the four breach the values, then you brand them as having gestational diabetes. So you do the screening test first, any time of the day, 50 grams, 1 hour later a glucose, and for Indian population I think we should pick 130 rather than 140 because there's more chance of getting diabetes. So what are the good things about ACOG criteria? The screening test again doesn't need fasting, and 15 to 20% need further testing to go on to the 100 gram OGTT. But again, the two-step process can be of nuisance value. இந்த குளுக்கோஸ் அதுவும் குடிக்கிறது ரொம்ப கஷ்டமான விஷயம் இன் பிரெக்னன்சி. ஒரு நாள் 50 கிராம் கொடுத்துட்டு அப்புறம் 100 அப்புறம் பேஷண்ட் அப்படியே ஓடி போயிடுவாங்க. ஸோ இட் இஸ் சம்திங் தட் வி ஹேவ் டு ரிமெம்பர் இன் அவர் செட்டப். கேன் மிஸ் அ சிக்னிஃபிகன்ட் நம்பர் ஆஃப் GDM பிகாஸ் யுவர் ஸ்கிரீனிங் டெஸ்ட் is based on a 1 hour value which is very poorly reproducible. நிறைய ஸ்டடிஸ் பண்ணிருக்காங்க GTT-ல. these 1 hour values are poorly reproducible. நீங்க அடுத்த நாள் பண்ணீங்கன்னா என்ன வேல்யூ இருக்குன்னு நமக்கு தெரியாது. So it is possible to miss a significant number of GDM and 3 hours of testing and quite a big load of glucose. So again, it's something to remember in our setup. I don't personally use this. And the last one is this IAD-PSG criteria. இது வந்து overnight fast for 8 hours. You ask the patient to come, women to come fasting. மூணே நம்பர் தான் ஞாபகம் வச்சுக்கணும். 92, 180, 153. Again, கொஞ்சம் confusing set of numbers, but remember any one of the three, if it is positive, then you brand the women as having gestational diabetes, and the glucose load is 75 grams. What are the good things and bad things? This is one study with a lot of evidence base. There were more than 20,000 subjects in the HAPO study, hyperglycemia and adverse pregnancy outcome study. The only disappointment is that there were not Indian women in the study. So the critics say that this is not suitable for our population. It's a one-step process. The cons are it's an observational study, and we don't know whether treatment at these levels make a big difference, and you're going to increase the diagnosis of GDM. But this is a good paper. I would suggest all of you to go and have a look at this paper. This was published in 2014, saying that the introduction of this new criteria for the screening and diagnosis of gestational diabetes results in improved pregnancy outcomes at a lower cost. This is the first time that there is an international paper which says that using this criteria reduces adverse outcomes and is cost effective as well. So they compared the ACOG criteria against the criteria in 2 years. And what they found is the use of this new criteria resulted in increase in GDM rate, but there was a big improvement in pregnancy outcomes. So the application was associated with a 3.5-fold increase in GDM prevalence, but significant improvements in pregnancy outcomes and cost effective. So at least there is some real evidence for this criteria. So I just want to summarize these 3 tests. There's no harm in me repeating this again because I believe use one of the 3. Just don't go for random glucoses or ask the patient to go and get a breakfast and do glucoses. That's not the way to do. Either you do the DIPSI, give a 75 gram glucose, 2 hours later more than or equal to 140. ACOG, give a 50 gram challenge anytime, 1 hour more than 130, go to step 2 and remember these numbers or write it down or look into the internet. And IAD PSG, overnight fast, 75 gram glucose, 92, 180, 153, any one of the 3 is diagnostic of GDM. So what we did in our setup is, we called all the gynecologists, all the endocrine and diabetologists, and we formulated this. We said that we are only going to use this. We don't know whether it's right or wrong, but let us use the same thing. So whichever setup you're in, please get together, discuss the pros and cons, and use one protocol so that it's easy to audit our practice. I think my take-home message on screening and diagnosis is, there should be no controversy on universal screening in India. Please check glucose levels in any pregnant women. There are 3 protocols. Use one of them, but be consistent about it. Just keep using the same thing and audit your data. Personally, in our institution and for myself, I use the International Association Diabetes Pregnancy Study Group criteria because it's based on quite large evidence. And please audit your practice. At least start collecting. Now we've got a database of all the women with GDM based on this protocol, and let us see what the outcomes are. Next one is use of oral agents in pregnancy. Idhukku oru chinna case vechirken, but nariya metformin bashing irukku pregnancy. I've had senior consultants come on stage saying that metformin is dangerous in pregnancy, it can cause rupture of uterus. I've had gynecologists who are very happy using metformin in PCOS throughout pregnancy, but very reluctant to use metformin in GDM, saying that it can be dangerous. So we'll have some clarity on it. It's up to the audience now. This is a lady with GDM, given diet and lifestyle advice, and regular capillary glucose monitoring shows the fasting glucose to be around 95 to 105, 2 hour 130 to 150 over the next 2 weeks' time. Who would say these targets are reasonable? She should continue with diet and lifestyle alone. Anyone? What are the targets we use? Anyone? 1 hour? 1 hour less than 140, 2 hour less than 120. Again, a lot of centers use 1.5 hours. I think based on whatever evidence is now available, use any one of the 2. 1 hour less than 140 or 2 hour less than 120. Oral agents, I'm not happy to use it. I would never use metformin in pregnancy. Anyone? Please be brave and raise your hands. Madam, you use panningala, madam. Only insulin. Okay.
And not this patient.
So you wouldn't use metformin in any pregnancy?
Not diabetes.
Yeah, sure. Metformin is a reasonable choice. I would start this lady on 500 milligrams twice daily and add insulin if needed. Anyone? Okay. Few hands raising up. Good. And insulin is the gold standard treatment in pregnancy. Madam, neenga sonadhu, I'm uncomfortable using oral agents till more evidence. So let us see what it is. The main worry about using metformin in pregnancy are these things. Does it cross the placenta? No long-term experience with it. No big randomized controlled trials. Is it really as efficacious as insulin? Is there a worry about congenital anomalies? And what happens to these babies who are exposed to metformin? These are very logical questions we shouldn't ignore. So, நம்ம நினைக்கிறோம் என்னமோ metformin new concept first எப்ப யூஸ் பண்ணதுன்னா 1960s. Would you believe this? And there was a guy in South Africa, Coetzee. இவர் வந்து இந்த ஜோஹானஸ்பர்க்ல வந்து he was treating a lot of very poor South African Caribbean population where they didn't have access to insulin. சரி எதுவுமே போடாததுக்கு at least metformin போடலாம்னு நினைச்சார். And to his surprise he found that the outcomes were really good. And this paper came in 1980 in South African Medical Journal. And in the NICE guideline வரதுக்கு முன்னாடி அவர் எழுதிருக்காரு, glibenclamide and metformin appear to be safe drugs during pregnancy when properly used. So it's not a new concept. இது ஒரு 40-50 வருஷமா யூஸ் பண்ணிட்டு இருக்காங்க. நமக்கு தான் தெரிய மாட்டேங்குது. And what happens? இது இந்த பேப்பர் நீங்க கண்டிப்பா எல்லாரும் பார்க்கணும். இது 2015 BMJ ல வந்த பேப்பர். Just author name நோட் பண்ணிட்டு கூகுள் பண்ணுங்க நீங்க. This is a big meta-analysis of only randomized controlled trials using metformin, glibenclamide and insulin in GDM. And what did they find? Glibenclamide வந்து compared far inferior to insulin. Insulin was much better than glibenclamide. But if you compare metformin versus insulin, metformin was much better. And if you compare metformin versus glibenclamide, again metformin was much better. So what they summarized was when compared with insulin, metformin is associated with less maternal weight gain, lower rate of neonatal hypoglycemia, less pregnancy-induced hypertension, less macrosomia, and more patient satisfaction and preference. And glibenclamide பத்தி நிறைய பேசுறாங்க. I have not had any personal experience using glibenclamide, but metformin again is far superior to glibenclamide on any of these parameters. And in the study that we frequently quote pannadhu is the MIG study. So idhu neenga Google pannunga, you get a free full text article, metformin in gestational diabetes study, MIG trial. And what they said was there is no difference between metformin and insulin in terms of all the big outcomes. Importantly, both the mother and child are okay if you give metformin in gestational diabetes. About 50% needed supplemental insulin, but I say that 50% are not needing insulin. So it's the way you look at it. And we are worried about metformin and babies. Again, adukku enna evidence? PCOS la dharmathukku use pannittu irukom namba. Adukku evidence irukana? Actually, there's no big evidence for continuing metformin throughout pregnancy if you strictly look at randomized controlled trials. But this is a paper again in 2014 looking at first trimester exposure to metformin and risk of birth defects. It was a very large systematic review and analysis, and again there was no difference between the metformin group and the not metformin group in terms of major anomalies, 0.6% and 0.5%. Compared to those treated with metformin and who are not on metformin. So it's very reassuring to see this. And again, in the MIG-TOFU study, follow-up study of babies born to metformin mothers for about 2 years. And again, they didn't find any big worry. If at all, they said that there was some beneficial, there may be some beneficial effect in increase in level of subcutaneous fat. Again, these are all very iffy things. We don't know whether it's true or not. And personally speaking, I've used metformin a lot over the last few years in pregnancy. We've got our own publications, metformin in diabetes pregnancy and experience of metformin use in gestational diabetes. I find it a very safe and easy agent to use as far as you talk to the patient, document in your notes that you have discussed, and you have to say that it's not a licensed indication. Few hands raising up. Good. And insulin is the gold standard treatment in pregnancy. Madam, neenga sonadhu, I'm uncomfortable using oral agents till more evidence. So let us see what it is. The main worry about using metformin in pregnancy are these things. Does it cross the placenta? No long-term experience with it. No big randomized controlled trials. Is it really as efficacious as insulin? Is there a worry about congenital anomalies? And what happens to these babies who are exposed to metformin? Idella romba nyayamana logical questions we shouldn't ignore. So, நம்ம நினைக்கிறோம் என்னமோ metformin new concept first எப்ப யூஸ் பண்ணதுன்னா 1960s ல. Would you believe this? And there was a guy in South Africa, Coetzee. இவர் வந்து இந்த Johannesburgல வந்து he was treating a lot of very poor South African Caribbean population where they didn't have access to insulin. சரி எதுவுமே போடாததுக்கு at least metformin போடலாம்னு நினைச்சார். And to his surprise, he found that the outcomes were really good. And this paper came in 1980 in South African Medical Journal. And in the NICE guideline, glibenclamide and metformin appear to be safe drugs during pregnancy when properly used. So it's not a new concept. இது ஒரு 40-50 வருஷமா யூஸ் பண்ணிட்டு இருக்காங்க. நமக்கு தான் தெரிய மாட்டேங்குது. And what happens? இது இந்த பேப்பர் நீங்க கண்டிப்பா எல்லாரும் பார்க்கணும். இது 2015 BMJ ல வந்த பேப்பர். Just author name நோட் பண்ணிட்டு கூகுள் பண்ணுங்க நீங்க. This is a big meta-analysis of only randomized controlled trials using metformin, glibenclamide and insulin in GDM. And what did they find? Glibenclamide compared far inferior to insulin. Insulin was much better than glibenclamide. But if you compare metformin versus insulin, metformin was much better. And if you compare metformin versus glibenclamide, again metformin was much better. So what they summarized was, when compared with insulin, metformin is associated with less maternal weight gain, lower rate of neonatal hypoglycemia, less pregnancy-induced hypertension, less macrosomia, and more patient satisfaction and preference. And glibenclamide பத்தி நிறைய பேசுறாங்க. I have not had any personal experience using glibenclamide, but metformin again is far superior to glibenclamide on any of these parameters. And in the study that we frequently quote pannadhu is the MIG study. So idhu neenga Google pannunga, you get a free full text article, metformin in gestational diabetes study, MIG trial. And what they said was there is no difference between metformin and insulin in terms of all the big outcomes. Importantly, both the mother and child are okay if you give metformin in gestational diabetes. About 50% needed supplemental insulin, but I say that 50% are not needing insulin. So it's the way you look at it. And we are worried about metformin and babies. Again, அதுக்கு என்ன evidence? PCOSல தர்மத்துக்கு யூஸ் பண்ணிட்டு இருக்கோம் நம்ம. அதுக்கு evidence இருக்கானா? Actually, there's no big evidence for continuing metformin throughout pregnancy if you strictly look at randomized controlled trials. But this is a paper again in 2014 looking at first trimester exposure to metformin and risk of birth defects. It was a very large systematic review and analysis, and again there was no difference between the metformin group and the not metformin group in terms of major anomalies, 0.6% and 0.5%. Compared to those treated with metformin and who are not on metformin. So it's very reassuring to see this. And again, in the MICTOF study, follow-up study of babies born to metformin mothers for about 2 years, and again they didn't find any big worry. If at all, they said that there was some beneficial, there may be some beneficial effect in increase in level of subcutaneous fat. Again, these are all very iffy things. We don't know whether it's true or not. And personally speaking, I've used metformin a lot over the last few years in pregnancy. We've got our own publications, metformin in diabetes pregnancy, and experience of metformin use in gestational diabetes. I find it a very safe and easy agent to use as far as you talk to the patient, document in your notes that you have discussed, and you have to say that it's not a licensed indication.